Good afternoon, everyone, and welcome to the Support Hospital Opioid Use Disorder Treatment, Shout Texas Echo. Please note that we are recording these sessions for later distribution. Know that your names do not appear on the recording of the session, nor does anything listed in the chat. Thank you all for joining us today. My name is Shreya Prasanna, and I will be facilitating this session. A few quick announcements before we begin. To help us with attendance, please enter your name, affiliation, and email into the chat function to help us with our record keeping. We appreciate your support in helping us fully capture this record. We'll have to see everyone's smiling faces, so if you're comfortable and able, we encourage you to join by video, especially for the discussion portion of our session. We invite everyone to speak, but ask that you stay muted unless you're speaking. To mute and unmute, use the microphone icon on the bottom left of your screen if you've joined by computer, or if you've joined by phone, press *6. You can also communicate with the chat feature to raise questions and share comments. Please note that no protected health information is allowed either in the chat or our discussions. During and after the session, the Shout Texas Echo team will send out a link to an evaluation of the session. All participants filling out the survey will be automatically entered into a raffle for $30 Walmart gift card. So please go ahead and participate in the survey. Our didactic today is on integration of psychiatry into hospital SUD services. Following that, we will discuss a case presented by Katie Skiba. We will start with introductions, followed by didactics, announcements, case presentation, and open discussion. Thank you again for joining us at today's Echo. In the spirit of all teach and all learn, we encourage you to share your experiences, questions, and insight in today's discussion. With that, we'll do some introductions of our team here. Dr. Walker.
Hi, I'm Blair Walker. I'm one of your kind of hub content experts. I'm at Dell Medical School and I'm with Psychiatry.
Thank you so much. Dr. Ramesh.
Hi, I'm Dr. Ramesh. I'm from Dell Med and I'm a internal medicine hospitalist.
Thank you for joining us. Dr. Moriartis.
Everyone, Chris Moriartis, hospitalist, Assistant Dean for Healthcare Value, Associate Chair for Quality and Safety at Dell Med. I'm part of Shout Texas and the hub team here.
Thank you. Dr. Lindsay.
Hi, Adrienne Lindsay, Director of the Be Well Texas SUD Telementoring Institute. Thanks for being here, everyone.
Thank you so much for joining us. Katie Skiba.
Hi, I'm Katie Skiba. I'm the Manager of Comprehensive Care Management at Baylor Scott & White Memorial Hospital in Temple, and I am a social worker by license. So thank you for having me.
Thank you so much. Alana?
Hi there, everyone. I'm Alana Bolton. I'm a program manager at Dell Med, specifically over our Shout Texas program.
Thank you so much for joining. Andrea Hebler? You're muted, Andrea.
How about now? My name is Andrea Hebler, and I'm a project coordinator for ECHO. I'm happy to be here.
Thank you so much. With that, we'll get started with our didactics for today. Dr. Walker, you can start whenever you're ready. Thank you.
Can y'all see that okay? My shared screen? Yeah, great. Thanks for coming. Thanks for having me. So like I said, I'm with Psychiatry. I'm a consultation psychiatrist in the Ascension Seton Dell Medical School arena. I was asked to talk about integrating psychiatry into substance use disorder treatment in the hospitals. And so just to kind of briefly review learning objectives, we'll talk a little bit about hospital-based psychiatry services that can be applied to substance use disorder treatment, talk about how psychiatry can be kind of appropriately engaged in that patient care, and talk about our main example, which is our own particular treatment model and kind of how it works. There we go. So first of all, there's a lot of overlap between substance use disorder and mental health disorders. I interestingly heard this morning on NPR a psychiatrist who has his own addiction history talking about labeling addiction as a disease is very problematic. But they do have overlaps, and there are a lot of different contributors potentially to both. And so we see genetic and environmental risk factors that are similar for both: family history, history of stress and trauma, and gene changes that can be caused and then passed down amongst generations. Mental disorders or psychiatric disorders can contribute to substance use. We see people self-medicate. We see some drugs temporarily help symptoms of psychiatric disorders, but then can make the symptoms worse over time. And we also see that some brain changes can make folks with psychiatric concerns have a little bit more rewarding effects from substances. And then vice versa, substance use disorders can contribute to the development of psychiatric disorders and psychiatric symptoms, and can change kind of brain structure and function, make them more likely to develop a psychiatric concern. So for instance, we see fairly often chronic use of amphetamines in a individual who maybe had some genetic risk factors. There's no one in their family that necessarily has schizophrenia, but now they do. And even when they're sober, they've now developed a psychiatric disorder. And is that partly because one kind of begat the other? There's a little bit of chicken and egg here and there, but I think that's where it's useful to have psychiatry input to try to help. So how can we be useful? There are quite a high propensity of comorbid dual diagnosis substance use and mental health. And I think psychiatrists in particular, it's hard to parse out whether you have an underlying psychiatric disorder or not when someone is struggling with substances. It often confounds kind of the diagnostic picture. So I think enrolling your psychiatrist to try to help pick that out over time can be really useful. We're also skilled in psychopharmacology. Many of us have very robust training in different therapeutic techniques in general, including motivational interviewing. And in the hospitals, the psychiatrists that are working in medical hospitals are usually pretty good at talking to patients, setting boundaries, dealing with patients who are struggling to engage in care appropriately. And we're also often kind of helpful with second opinion capacity evaluations. And sometimes in this patient population, you're going to need help with that. So to talk about kind of what is out there, hospital-based psychiatric services. So I'm a CL psychiatrist, a consultation psychiatrist. We are often the sort of de facto available psychiatry in medical hospitals. And so I thought it was interesting to sort of pull apart, just so that everyone knows kind of what the different training requirements are for these different things. So all psychiatrists have 4 years of adult psychiatry, and then plus minus a fellowship. So for consultation psychiatry and addiction psychiatry, we both do fellowships. The difference in the fellowships is that CL psychiatry has particular expertise in caring for complex medical patients in medical hospitals more than anything. So it really includes a pretty robust training in kind of addiction and withdrawal, and then managing kind of behaviors in the medical hospital, versus addiction psychiatry that's doing maybe some in medical hospital. For instance, our addiction fellows come to work with us on Mondays for 6 months of their year training, but they're spending a lot more time in outpatient treatment and pure addiction treatment that might not have dual diagnosis and definitely might not be in the medical hospital. So there's a little bit of difference there. And then the addiction medicine training, which I'm actually hoping to be addiction medicine qualified, waiting to hear how I did on my board exam. But basically, it's 3 to 4 years of any ABMS specialty, including psychiatry. So you can have medicine docs who have addiction medicine and do an additional fellowship, or have grandfathered in because they've been doing all of this work for a number of years. There's still a grandfather window for that, and that's what I'm doing. Or you might have a psychiatrist, or you might have somewhere in between. And so, sort of knowing somebody's training might help you understand like where their particular expertise may lie. I thought it was interesting to kind of pull that apart. So to give you an example of how we've integrated psychiatry, our B team here at Dell Seton, I kind of take a major provider clinical lead, especially because I'm more flexible with time. And in these last couple of years with COVID surges, our hospitalists like Jan and Chris are on very, very busy COVID teams, really too busy to stop and go off to see a one-off patient to help, the surgery team or the other team. So psychiatry consultants in the hospital are usually more flexible with time and available. Dual diagnosis is common. So there's actually, I would say, even a majority of our patients at our hospital end up needing a little bit more nuanced psychopharm, kind of in addition to getting them onto Suboxone or methadone or whatever we're going to do. And then we also have quite a bit of dual substance use disorder folks. So some nuanced withdrawal. It gets a little tricky when you're withdrawing from different substances. My ideal goal, and we'll get there, is to sort of have general screening and expert with a team that doesn't necessarily need to be a doctor, and then opioid use disorder initiated by the primary team, theoretically all the primary teams, and then consult psychiatry only if it's indicated for like extra nuanced stuff. And we are seeing our medicine primary teams at our hospital. We have been here so long, and we have so many champions in medicine who are B team providers who have developed the expertise and have disseminated it amongst their colleagues, that I almost always don't ever need to see those patients, other than if the day of discharge they happen to not have an ex-favored provider to prescribe it. And so that's been a really rapid change, I think, in our hospital. But in general, I think that the takeaway is, if you're going to be developing or have developed an addiction service in your hospital, if you have psychiatry available, there's a lot of overlap. I think it's really important to include psychiatry in the discussion and planning so that you can kind of meet the patient and hospital needs to the best of your abilities without doing too much overlap, and kind of working together in the most effective way possible. Those are the references where some of these slides came from. And I wanted to open it because we have lots of time for the case discussion. If anybody has any particular questions for me about this, about B team in general, thoughts, concerns, and if not, we'll go on to the case discussion. Nope.
Thank you so much, Dr. Walker, for your insightful presentation. I will open up the floor to our learning network here. See if you have any questions, comments.
So let's get started with the case.
You will go to announcements then, because we have some announcements and updates that we want to share. Echo IT, if you can please share the announcements. Thank you so much. I will now pass it on to Dr. Lindsay to introduce us to Be Well, Texas.
Thanks, Shreya, and thanks for that great presentation, Dr. Walker. So just one exciting announcement, because you're probably seeing new names on our virtual backgrounds here. So we just wanted to let everyone know that Texas Mood is now Be Well Texas. So we had a pretty substantial name change. I know you've seen a lot of communications from us in the past with kind of that Texas Mood name and probably seen our website and all those good things, but just be aware that we have this newer name to kind of encapsulate the broader array of things that we're doing. And we're still certainly doing a lot of work around medications for opioid use disorder, still a huge part of what we do. But we're doing much more beyond that. So we needed a name that would, again, kind of capture the broader range of things that we're doing. So if you move to the next slide, there's a brief visual there just to give you a sense of what all of those new things that we are doing. So everything under this Be Well Texas umbrella ranges from clinical trials to research to direct care services, recovery, smartphone apps, and of course telementoring that you all are taking part in right now in the form of ECHO. And we'll really be expanding those telementoring services as well beyond ECHO, including a hybrid virtual conference. And you'll see some new webinar offerings from us and things of the like. But just be aware that all of this is sort of happening under that Be Well Texas umbrella across the state. And so again, we wanted a name that can kind of reflect that array of things that we're doing. And one particular initiative that we want to draw your attention to, and it's on the next slide here, is our virtual clinic. So of course, the purpose of this ECHO and some of our other ECHOs is to make addiction medicine services more accessible, but we also want some services to kind of catch anyone that might be falling through the cracks. So if you have a patient in a remote area without any nearby providers, or a patient that's having difficulty paying for, say, their medications, our virtual clinic, the Be Well Texas clinic, is available. So you see the 800 number here as well as the website, and those patients can be seen entirely virtually if they are comfortable with that. So I will turn it back over to Shreya for some additional announcements.
Thank you so much, Dr. Lindsay, for that introduction. So our next Shout Texas Community of Practice ECHO is on Thursday, February 17th. And please join us. We have some exciting speakers. Next slide, please. The Texas Substance Use Symposium is happening on March 24th and 25th in Corpus Christi with in-person and virtual options. To learn more and register, please check out their website, texassos.org. Next slide. The next Texas session is on February 8th, which is a Tuesday at 12 noon. Please join us. This is a very pertinent topic, which I'm sure many of us are interested in. Thank you. We will now move on to the case discussion. ECHO IT, if you can please share the case. Katie, whenever you're ready, please.
Hi, good afternoon. Thank you for allowing me to present this case to you. I have a presentation for you on a 43-year-old white male with extensive medical history to include type 1 diabetes. And the questions that I'm presenting to you is, what is your recommendation for reduction of readmissions and hospitalizations for this patient? The second question I'd like you to consider as we look at his case is in case of weaning off Dilaudid to Suboxone, how long is a reasonable wait while respecting the patient's rights? And then what, in your experience, is the success rate of the wean? And then, of course, what health behavior treatment plan would you recommend? And I really appreciate Dr. Walker's presentation. I'm a social worker by license, and I manage the comprehensive care management department here. But we work really closely with psychiatry in any case where it's relevant, but also in particular with our outpatient addiction psychiatrists here at Baylor Scott & White. And so this particular patient I chose because it was one of the ones that I had had the idea to try the wean for potentially reducing the number of readmissions this patient has. So the patient, and when I did this case, I'll just let you know, I finished the case, and when I went back in, he had had 4 more admissions. And so I had to sort of go back and redo everything. So some of this was the original admission that I looked at. And then he's currently in a different hospital right now. So he has had extensive medical history to include the diabetes, numerous episodes of DKA, polyneuropathy, lots of admissions due to problems with the end-stage renal disease. He is on hemodialysis Tuesday, Thursday, and Saturday. And but he also comes in for chronic generalized abdominal pain. He's had a history of medical noncompliance with his medication and attending dialysis. He also has hypertension, hyperlipidemia, recurrent C. diff infections, chronic diarrhea, numerous bacteremic episodes, including mycobacterium, and then frequent hospitalizations due to nausea, vomiting, and high sugars. He has had 5 hospitalizations since August 30th. And so I'll say that's 9 now. He has only been home for less than 2 weeks total since that time. The most recent discharge is incorrect at this time because he's currently in a hospital right now. But the one that we are looking at in terms of the details on this case was this epigastric pain with nausea and vomiting. But he had also reported hyperglycemia. So when he presented to the hospital, he had dialysis and was concerned that he possibly had an infection. He chronically has diarrhea, and that pretty much goes along with his every single admission or emergency department visit. He did report that he had edema that goes up and down, and it's been stable without rashes. He also reported chronic fatigue and generalized weakness that had worsened since August due to inactivity from hospitalization. In the emergency department, you can see that what his stats were there. He did have a chest X-ray with similar small pleural effusions. He had a CT abdomen. His pelvis was out contrast. He does have thickening of the rectal wall. When they were discussing this with him, he refused to have a rectal exam. So they were trying to see if he had underlying mass. And then you can see the rest of his statistics there. He has had, you can see the most recent hospitalization that I was involved in. He had presented with intractable nausea and vomiting. On 12/31, he came to the ED because he ran out of his Dilaudid. He came on the 29th because he had a bleeding dialysis catheter. He was admitted to the hospital for DKA from 12/15 to 12/28, also a sepsis secondary to bacteremia. His longest stay lately was due to sepsis without acute organ dysfunction due to proctitis. And then he also had a hospitalization in November due to noncompliance of insulin. The rest of the hospitalizations there listed were due to nausea and vomiting and bacteremia. He has a long history of anemia. He has recurrent bacteremia. He has chronic generalized abdominal pain. He is a type 1 diabetic, brittle, and he has a history of DKA. He also has end-stage renal disease, and he's currently on hemodialysis. He has hypertension, GERD, and hyperlipidemia. He has a long history of hypertension, which complicates his diabetes. And then he also has a recurrent C. diff, which we talked about before, a tobacco abuse disorder where he smokes regularly. And then following this, you can see the medications that he's currently taking. At home, he takes Tylenol, amlodipine, and you can see the rest of his medications here. He's taking clonidine. But I think the one that I wanted to most note was that he does take Dilaudid on an outpatient basis. He is currently on Zoloft, and so that was the other consideration that I was looking at, was what is going on with his mental health. You can see his hospital medications, and of course, I'm not a doctor or a nurse, but you're welcome to ask any questions about the medical history that I presented. The social history is what I'm most familiar with him. He does live with his 2 aunts. He is divorced. He has 3 children. He doesn't have a lot of support from his nuclear family. I did recently find out that he has a 24-year-old daughter that is somewhat supportive, but mainly his 2 aunts with whom he lives are his medical power of attorney, and he also is able to access transportation through them. He's a high school graduate. He was a truck driver, but was working until he was diagnosed with end-stage renal disease. So now he's unemployed. He does receive disability. He's at about 70% of the federal poverty level in income, and he has Medicare and Medicaid as his benefit coverage. He does report that he uses oxygen at night, only just for comfort, because he says he has a hard time breathing. And he's also in our Quality Alliance case management. So he has regular phone call follow-up, but in reviewing his case, they are rarely able to get a hold of him. He also has participated in a transitional care program. And so as I looked at everything in terms of social determinants of health, he seems to have everything that he needs in terms of financial resources, transportation, social connections. He does not use alcohol anymore. He reported a heavy use about 14 years ago. But he does, I didn't see that he had depression before when I originally did this, but then when we went back and looked at the psychologist's recommendations, he did show that a persistent depressive disorder, which is what he takes the Zoloft for. And then of course he smokes regularly, and so is at high risk for that. So in the hospital course, they were able to treat his sepsis, and it was resolved. And he was able to be discharged from this particular hospitalization. But in the middle of the hospitalization, we had made a referral to the Shout grant program that we have. And so one of the ideas to try to reduce his readmissions was to reduce his dependence on Dilaudid. And so we did make that referral, and addiction psychiatry, the provider and the psychologist evaluated the patient, who verbalized he was in agreement with weaning off of Dilaudid. And so overall, like, he did meet the criteria for opiate abuse by numerous prescriptions for Dilaudid and prescription drug monitoring program website Prescribing History. So we began the wean on 12/5 for the transition to Suboxone, and he agreed that this was a good decision. He evaluated on the 5th at 7:13 with a cow of 11. At 10:24, the cow was 14. And then at 1700, the patient became really tearful, asked to talk to the doctor, and told the doctor that he wanted to go back to Dilaudid and refused the next dose of Suboxone. So the patient didn't tolerate the wean due to the symptoms of pain and nausea. And so the doctor decided to go ahead and continue to the 4 milligrams Q4 of the Dilaudid. So I, everything was set up for this transition to Suboxone, including the appointment with the addiction psychiatrist. And then we were also going to have an ongoing evaluation by mental health and psychiatry. But because it wasn't successful, he was discharged. And as you can see, he's continued to return to the hospital for various reasons. But as I looked through it, he doesn't appear to have the social support problems as he self-reports that he has what he needs in terms of medication, transportation, benefits, but he has complex medical problems. He is independent in all his ADLs. And the themes that I see throughout his readmissions are DKA, sepsis, pain, and missing medications. Every time social work meets with him, he reports no needs. The transition to Suboxone was that one idea where social work and psychiatry were trying to work together to address these hospitalizations. But then in December, he went to 3 different hospitals for reasons related to the DKA, pain, and needing more prescriptions because of the holiday. One of the ED visits, he had a fall, and so we were digging into the reason behind that. He doesn't drink alcohol. He said it was just an accident, but his health behavior and his management of it is erratic because he also leaves the emergency departments frequently if the wait's too long or if he's not getting the treatment that he thinks he needs. We have made sure that his dialysis is scheduled and that he has transportation to get there Tuesday, Thursday, and Saturday, but he has also refused home health care or any other caregiving service. Other interventions that we've tried are a virtual discharge care coach program, case management virtually, and then of course, here in Temple, we have a complex care team made up of our leadership and our medicine teams, psychiatry, pharmacy, social work, and therapy. So we've all cased his situation, and that's how the getting him referred to this the Shout grant program came about. In one of his admissions in November, the social worker actually spoke to his aunt with his permission, and she said that he does his own thing. He's non-compliant. He sleeps all the time. He doesn't take medication the way he should or eat properly. And she's encouraged him multiple times to manage his health behavior better. But I did note that he was evaluated by psychiatry in November. He was found to be able to have decisional capacity independently. So he has the right to make his own decisions to manage his health care in this way. you look at his substance abuse. He used to drink heavily, but he quit 13 years ago. He used to use cannabis, but he said that was about 25 years ago. He smokes half a pack of cigarettes a day and has for 27 years. And he also uses snuff. I didn't see any history that he has had substance use counseling. And it seems that, we did try the substance use treatment within the hospital, but that was the only time. And so really the substance that he is addicted to is Dilaudid, and he does have pain that warrants pain medication. So I didn't see any history that he's had any participation in 12-step groups. And I did take a review on his, I didn't see any correlation between cultural, spiritual, or ethnic factors. So I would love to hear your thoughts and questions if you have any. I don't know what else to do. So
this is Dr. Perez, Veronica
yes.
Perez. I'm the addiction psychiatrist. I saw this patient, I believe. So I have a couple concerns about what went wrong on our end and what we could do better. So when I was consulted, I primarily work outpatient. So when I was consulted for this person, I went during my lunch break to meet him, just kind of motivate him, talking points about why it would be a good idea to switch to buprenorphine. He was very anxious about it, very reluctant, said that he'd like to speak to the hospitalist before making a decision. Some of my talking points to him were that this is longer acting. He wouldn't have to taper off like he's been doing with the Dilaudid. He could follow up with me. I can meet with him weekly to make sure that he was doing okay, in all aspects of his life. He did express that he wanted to go back to work. That was important to him. And we talked about how being on buprenorphine would allow him to do that if he was physically ready at some point. So with all that, I guess, I instructed the hospitalist on how to start the weans and start buprenorphine more than 4 milligrams, because I know that would not be enough given his history. I think that's where it failed, is that he was not titrated higher per the instructions. And I didn't even know that he had been discontinued until 2 days later when I reached back out and say, hey, how's he doing? So I think there was a communication error. There something fell off in between there. I wish that I would have been inpatient so I could have gone and talked to him and just continued to motivate him and reassure him that we would get him to feeling better. But unfortunately, I didn't know until it was too late. So I think if he does return, I would like that opportunity again. I think that could be helpful. But we'd have to increase that communication to make sure that I could maybe be more assistive in the moment, I guess. So just from my perspective. And also I did have him, I wanted him to follow up with me immediately after he discharged to ensure there was a smooth continuity of his care. He was actually blocked from our clinic because of past no-shows. And so I had to get him unblocked and get him, an appointment with me, which did not happen. So yes, we welcome any ideas to make this better and offer more support.
Thank you so much. This is really a very complicated case. I saw a question from Megan earlier. Megan, would you like to unmute, please?
Hey guys, my name is Megan Clark. I'm a PA. I've got an ER background for about 11 years and just started working in OUD about 3-4 months ago. So this patient speaks to me from an ER point of view quite a lot. He sounds really frustrating. I mean, you've got a guy with diabetes who keeps coming in with DKA, so he's not taking care of his diabetes. You've got a guy with proctitis who won't let anyone look at it. And I'm presuming he keeps coming back for Dilaudid, which someone keeps giving him. So I think we need to get the root cause of what keeps bringing him back in. Is it that he's trying to get Dilaudid? And if so, does the ER just kind of have to play hard and say, you need to go to your clinic appointments? You know, like, we can't keep seeing you for this. He seems like he's kind of going halfway on a lot of stuff. So I wonder what's really bringing him back. And I think y'all mentioned that he went to a few hospitals. So it sounds like he's hospital shopping for something. And we need to figure out what that is exactly. And he doesn't sound like he's really willing to accept a lot of help that's being extended. So that's got to be really frustrating for all of you guys on his team. You know, people are making efforts to make sure he gets his medicine and goes to his clinics, and he's just not doing it. So I kind of feel like this is one of those, you can lead the horse to water, but you can't make him drink type of thing. And if he doesn't want help with his substance use, you know, I don't know that he's really going to go for Suboxone if he's not ready to really try to come off of Dilaudid. I don't know. He's frustrating, but figuring out why he keeps going back, I think, is going to be clutch.
So this is Dr. Ramesh from Del Seton. I have a few initial thoughts about the case. Thank you, Katie, for presenting it. It's a really, really complex, really interesting case. And in regards to your question, we can jump maybe to the second one, since there seems to be some question about how best to wean this guy from Dilaudid to Suboxone. And I discussed with our addiction medicine doc here, Dr. John Weems, who I think unfortunately could not make it today. And after some discussion, we came up with some few points of discussion. One is, does this patient actually have an opioid use disorder or a chronic pain syndrome? And with a chronic pain syndrome, he would deserve some pain medications and a chronic pain regimen to address his pain. But buprenorphine would not be the first line treatment, especially since his pain is abdominal. And if it's an opiate use disorder, that should be determined with the DSM criteria of the patient wanting to cut down, but unable to fulfill certain aspects of his life because of his use. And so differentiating that is going to be helpful, because it's going to frame how you talk to him about buprenorphine. So if you make the decision that he has, opiate use disorder and he needs to be weaned to buprenorphine, explaining the rationale of buprenorphine, and I think it was explained that it would help him, it would be more long acting for him, so he'd have less intermittent withdrawal, and maybe even help with some of his GI symptoms as well. It seems like a lot of nausea, vomiting, and constipation are underlying some of these admissions. So that's one thing to discuss when, trying to sell the idea of the buprenorphine. And then in terms of dosing, it looks like there's two major methods that we use to wean short-acting opioids and start Dilaudid, and I think there's a little bit variation based on institution. The first method is, I think, what was maybe tried here, which is to wean the Dilaudid to a point that he starts entering some withdrawal symptoms, at which point you would start dosing with buprenorphine and then closely assess for the relief of withdrawal symptoms after 1 hour or 2 hours. Patients are really, at least in my experience, are super hesitant to go through this because nobody wants to go through withdrawal, even if it's mild or moderate. So one thing you can do is, and I'd love to hear other people's thoughts about this, support them with medications for their nausea, for their vomiting, for their diarrhea, with like loperamide or even benzos like Ativan, to sort of calm them down through this process. He's even on clonidine, which can be super helpful in the anxiety of weaning off the buprenorphine. But if he is someone who does not want to enter withdrawal, you can do fixed schedules of buprenorphine to be given every 2 to 3 hours at very, very small doses, like 0.25 or 0.5, and then slowly up titrate the next day and the following day, without actually requiring the patient to go into withdrawal before giving the next dose. The problem with this method is it takes a long time to get to that therapeutic dose level of 8 to 12 milligrams a day that he might need for his pain coverage. But the good thing about it is that since you're starting the buprenorphine at such low doses, there's less risk of precipitated withdrawal. You can actually continue supporting him with the short-acting Dilaudid as you go up on the buprenorphine. So those are maybe two different methods to kind of help and try again if he is willing. And I'd love to hear anybody else's thoughts if they've had experience with this, with like rapid microdosing or withdrawal-based symptoms.
Thanks, Dr. Ramesh. One big question that I have is, have the hospital doctors and outpatient providers been talking? So, I mean, trying to like fix something when I know he hasn't really been out for more than a couple of weeks, but I think you have to have kind of a continuity of care and sort of a general treatment plan, both in and out. Like Megan said, someone is giving him Dilaudid. It's still not clear to me either whether or not he does have opioid use disorder. Lots of prescriptions for Dilaudid doesn't necessarily mean you have it. You could just have physiologic tolerance. I also think we have to be really cautious about like unconscious bias. And I think, you know, I'm guessing that of course you guys have sat down and tried to talk to him about this. And what do you think drives leaving AMA? What do you think drives coming back? You know, but I think continuing with that discussion and trying to explore that. At some point, if it's pretty clear that this is driven by opioid use disorder, it's interesting the way you ask the question about how to wean given patients' rights. So in my opinion, patients don't have rights to medications in the hospital. We order what we think is safe, and they can decide to stay for the care that we're offering, or they don't have to stay and they can go elsewhere if they don't like the care that they're getting. And so sometimes, and I don't know if it's this patient, but you know, having that discussion of, we see that you've developed this pattern and we're pretty convinced at this point that you do seem to have a problem with Dilaudid. We think trying this other one would be a better idea. Get his buy-in again is that, you know, at this point, like anytime you come into our hospital system, if you can circle the wagons in the system to sort of have a treatment plan for him when he's with you. That's the kind of thing we do at our hospital. We see tons of patients who are struggling with readmissions. I think also kind of exploring to make sure what else might be contributing. It sounds like, you know, certainly when I see AMA, a lot of, you know, AMA discharges, substances is a big one. You know, he also smokes cigarettes. So making sure that that's attended to while he's in the hospital. But, you know, is this partly personality? And then, you know, trying to work on coordinated care and continuity of care as much as possible. So it's sort of, it can be tiring, but if someone can get in there with him and build some trust and see if maybe the same treatment team can get working with him. I'm also curious, in your area, do you have, you know, we have sort of more complex care outpatient clinics that have a little more wraparound support, because it's hard to navigate all this stuff. I'm also interested to know, does he get to, you know, again, I get he hasn't been outside of the hospital. Is also part of this, he can't get to dialysis? Does he get to dialysis when he's outpatient? You know, those sorts of things. Like, can he navigate any of it? Or is it just so overwhelming that he just ends up back in the hospital? I don't know. I think there's a lot there for him to, it just overwhelms me to even imagine having to deal with all of that. So those are sort of some of my thoughts about it.
I want to give other people time to respond. I just, I know he has some level of consistency with the dialysis, but the outpatient thought of connecting with someone, that's, I think, what's really missing here, because he's so between Waco and Temple, and kind of goes wherever he thinks is going to get what he needs. Getting some sort of continuity, I think, would be really the key, because he manages it sometimes, just not lately. So
does he go between different hospital systems?
Mm-hmm.
So I wonder if there's a way to liaise with the different treatment teams and try to develop some sort of community plan for him. We have a high alert program, we call it, in the Ascension system, and St. David's is our other system here, and we our alert leads like talk to each other and make sure that everyone's sort of on the same page with care plans for folks that are struggling to engage in appropriate care. So I wonder if something like that could happen for him. I mean, he sounds like a high utilizer, and it would probably be worth a meeting with some sort of champions of let's try to help this guy. I don't know. It's a very
idea.
frustrating case.
From the discussion that I see around, it seems that trust and communication looks like really important here. So I was wondering if the group had any strategies they've used before that they could recommend.
Hi, my name is Richard. I'm with Be Well Texas, and I'm going to come from a peer support perspective. And I think one of the things that I'm not hearing, and maybe it was said and I just missed it, but has anyone just sat down and asked him what he wanted? It's like, instead of us really telling him what the treatment plan is, just kind of really trying to engage with him and find out, what is it you really want? How can we help you get there? And maybe take that approach with engagement. And I know that's difficult when you don't really have that kind of time, as a medical staff or a psychiatry department, but it's just a thought.
That's a great thought. We have to make time. We're spending time anyway with readmissions and AMA discharges, right?
He may be able to provide some other information that maybe he doesn't really know yet, but if someone sat down with him and they kind of questioned him on that, it would make him maybe be more introspective and come up with something. Man, you got your work cut out for you. What a challenge this person is.
Sorry, I got cut off the call for a while. This is Veronica again. In regards, so he does have both opioid use disorder and chronic pain syndrome. The discussion when I had with them is that we need to address both. And, buprenorphine is not going to be the be all to his chronic pain for sure. He would need additional support. And I told him whether he wanted to start it or not, he should still make that appointment with me so we can continue to discuss. And then in regards to the withdrawal, yes, I've done Ativan, benzos, things like that before to help with the withdrawal process, because that is a big anxiety factor for people switching over. And then, yes, symptomatic medications for sure, because that's only ethical, but yes.
I just have a quick thought and comment, kind of back to Richard's point about communication and things and what does he want, what's motivating him. This case seems really ripe for motivational interviewing and using that communication technique. And I'm sure that's probably been utilized in multiple interactions with him, but there's so many pieces here where motivational interviewing is a good fit, from leaving AMA, just chronic health conditions in general, the substance use piece, and just kind of that disconnect between the treatment goals and the behaviors that the patient is engaging in, and kind of just getting back to basics. And one of the first stages in motivational interviewing that we talk about is just basic engagement, just getting back to building that working relationship with him and what's going on, what's motivating him, why they're popping around in the different systems, and what is he, someone else brought up the question of, what is he looking for? What does he want? And trying to show him that we're truly trying to meet him where he is, and just again back to those basic communication skills outside of the medical interventions that might be most appropriate. But
I think the idea with MI is sort of partnering with the patient rather than we want you to do these things and we're frustrated you're not. It's like, what do you want, and how can we help you? Maybe that'll help him build more trust as well. It'll be a process.
Yeah, and that style, to that point, that is one of the last stages, is planning, but often we try to jump ahead into the planning piece, whereas really we might want to again go back to basics and back to engagement before we try to make any suggestions or recommendations or try to develop the treatment plan.
So given he has so many issues going on, and I think we kind of touched earlier on this, but like, how do you triage the care in such a situation? And how does the patient's priorities factor into that discussion, right? I mean, do we consider what their priorities are, or do we focus on what's most pressing at the time? Any thoughts on that?
I just, again, with my ER hat on, triaging him. The most dangerous thing to him sounds like whatever's causing this recurrent proctitis. You know, there's a lot more history there. Is he a surgical candidate? Does he have something that's life-threatening? And making sure just from a life or death, what's the most immediate risk thing is figuring out if he keeps coming back with sepsis from proctitis, what that is, and does he need surgery? Because then it would be terrible to get him on Suboxone and then surgery jumps in and they're like, well, we've actually got to put him under, we have to wean him off Suboxone, and then you're in that mess. So I would first kind of think life critical wise, what's going on with his sepsis and what's the cause of that? Does he need surgery? Make sure that's not a situation. And then really, yeah, just ask him point blank, like, what can we do for you? That's what I got in the habit of doing. And sometimes they'll actually tell you and you can suss out if something you can actually help them with.
And I think from a medical perspective, you know, this patient has so many terrible chronic illnesses, some of which are progressive, some of which are end organ damage conditions that to some degree, we have to expect that he's going to keep coming back to the hospital for exacerbations of these conditions that we may not be able to control as well as we like. Even with ESRD patients, you know, 1 out of 4, 1 out of 5 end up getting readmitted within a month. DKA patients, 1 out of 4, 1 out of 5 end up getting readmitted within a month. He has both. And then he also has this chronic nausea, vomiting, diarrhea, constipation picture, which I wonder if that's affecting his absorption of his pain medications, if he's not able to keep his medications down. And then so he gets into this vicious cycle of nausea, vomiting, pain, nausea, vomiting, pain. So really trying to get to the root of that GI issue and as Megan said, the proctitis, I wonder if the proctitis is from chronic constipation from high use of opioids and whether that needs to be better managed. And even though he has this history of diarrhea from malabsorptive diarrhea, it could also, part of it could be overflow incontinence from constipation. And I think one of his CTs did mention that. So trying to attack the gastroparesis from like a surgical perspective, from a specialist GI referral, and the constipation as well might help with him tolerating his medications better. And also it seems like those symptoms are really important for him to control as well.
Thank you so much. We'll now move on to a summary of recommendations. I know a lot was discussed, so Dr. Ramesh, if you could quickly summarize it for the group.
Sure. So thank you all for this great discussion. Thank you, Katie, for bringing this case. We had some really good discussions about this complex patient, kind of going over how to diagnose if he has opioid use disorder or chronic pain syndrome and what might be the best methods based on what diagnosis he has. Really trying to understand what the patient himself wants and trying to establish that therapeutic relationship early on. And then making sure that the inpatient side and the outpatient side as much as possible is coordinated with his care, and trying to get the teams to talk to each other and come up with a comprehensive treatment plan for him. The continuity of care and those liaisons that were mentioned are super helpful. It's unfortunate that he's had to decline some of them, but keep going with that, I think could be helpful to him. And then as well as addressing these medical conditions that underlie his frequent readmissions and whether any of those symptoms and high-risk diseases can be optimized just a little bit more so he doesn't get stuck in this cycle. So a lot of different areas we can go through here. I think that it's going to be difficult moving forward. It might take some time for him to even see some improvement in even one of these areas, but I think great work for everything that has been done so far. And I hope this was helpful.
Thank you so much. Thank you everybody for joining today's ECHO session. As a reminder, to earn CME and CNE credits, please complete a post-session survey using the link in the chat. We look forward to seeing you at our next session on Thursday, February 17th. Have a great rest of your day and stay warm. Drive safe. Bye. Take care.
Bye, everyone.